Welcome to the deep dive. Ever had that, that annoying feeling in your eye, a bit red, maybe a bit scratchy, and you're just not quite sure what's up?
Yeah, that sounds familiar.
Well, today we're diving into episcleritis.
Yeah.
It's actually pretty common, pops up in exams, you see it in practice too.
Exactly, and it's often misunderstood, I think. Basically, think of episcleritis as a generally benign inflammation. It affects the eye's outer layers.
Right.
Specifically, the episclera, that's the thin bit of tissue kind of sandwiched between the conjunctiva, the clear surface layer,
Okay.
and the sclera, the white part of your eye. Usually you'll just see some localized redness, maybe mild discomfort.
Got it. So our mission for this deep dive is really to give you the absolute essentials on episcleritis. The stuff you really need to remember for revision. We've gone through the revision notes, trying to pull out the clearest, most concise info to, well, make it stick.
Good plan. So let's start with the definition, get that really clear. Episcleritis. It's a benign inflammatory condition.
Benign, okay.
Yeah, of the episclera, which sits, like I said, between the conjunctiva and sclera. Key things to remember. Localized redness, some discomfort, and it can show up in one eye or sometimes both.
Now, here's something that always seems to trip people up in exams, telling it apart from scleritis. What's the main difference we need to grasp?
Yes, that's absolutely critical. The big difference is depth, really. Think superficial for episcleritis and maybe serious or severe for scleritis.
Okay.
Both involve inflammation, sure, but scleritis goes much deeper. It hits the sclera itself, the main structural wall of the eye, so the pain is usually worse. The inflammation of the blood vessels there is more intense.
Right.
Episcleritis, like the name suggests, epi meaning upon, stays right on that surface layer.
Okay, got it. Episcleritis, surface, generally mild. Scleritis, deep, potentially much more serious. Now, are there any underlying health conditions often linked with episcleritis?
That's an interesting point. A lot of the time, maybe even most of the time, we actually don't find a specific cause. We call that idiopathic.
Right, idiopathic.
But we definitely see it more often in people who have certain inflammatory conditions, especially things like inflammatory bowel disease, so Crohn's, ulcerative colitis, and also rheumatoid arthritis.
Ah, okay.
So yeah, if someone keeps getting episodes of episcleritis, it's definitely worth thinking about those systemic links.
Good point. The notes also mention two main types, don't they? What are they?
Yeah, two main patterns. First is simple episcleritis. That's usually just a smooth, even redness across a section of the episclera, like a diffuse patch.
Like a blush, almost.
Yeah, exactly, like a blush on the white of the eye. Then you've got nodular episcleritis, and that's where you see a distinct raised little lump, a nodule, on the surface.
Okay, simple and nodular. And does knowing the type tell us anything about, say, how long it might last?
It can give you a clue, yeah.
Yeah.
Simple episcleritis usually clears up relatively quickly, maybe 7 to 10 days, something like that.
Not too bad.
No. Nodular episcleritis, though, that can stick around a bit longer. And it's also the type that's, well, more strongly associated with those underlying systemic diseases we mentioned.
Oh, okay.
So if you see a nodule, it might just prompt you to dig a little deeper into their general health history.
Right. Makes sense. So let's get into the why. What do we actually know about what triggers episcleritis? What kicks it off?
Well, like I said, the exact trigger often stays a bit of a mystery. It's frequently idiopathic, but the main thinking, the leading theory, is that it's immune-mediated.
Immune-mediated. So the body's own immune system.
Exactly. It seems to be the body's immune system kind of overreacting, causing inflammation in that superficial eye layer.
Okay. And we mentioned rheumatoid arthritis and IBD. Are there other systemic conditions that should be on our radar?
Oh, yeah. There's quite a list, actually. You should definitely think about other connective tissue diseases, things like lupus, polyarteritis nodosa, granulomatosis with a polyangiitis, those sorts of conditions.
All right.
Also, hyperuricemia, that's high uric acid levels, like in gout, that pops up in maybe 11% or so of cases.
Yeah.
So it's definitely worth considering, especially if the episcleritis keeps coming back.
Okay. What about infections? Can they trigger it sometime?
They can, yes. It's less common than idiopathic or autoimmune links, but certain infections have been implicated. Viruses like herpes zoster shingles and herpes simplex.
Cold sores.
Yeah. Also some bacterial causes like Lyme disease, syphilis, even things like hepatitis B and brucellosis have been linked. And then there are sort of miscellaneous associations too, things like rosacea, atopy, general allergic tendencies, even thyroid eye disease. Sometimes it might just be a reaction to, say, a tiny foreign body or a chemical splash.
And are there any really, really rare causes listed? Stuff you might only see in textbooks?
There are a few, yes. Very uncommon. But things like T-cell leukemia, paraproteinemia, certain paraneoplastic syndromes, even rarer things like Wiskott-Aldrich syndrome, adrenal problems, or progressive hemifacial atrophy have been reported in isolated cases. But honestly, for practical purposes, the vast majority are either idiopathic or linked to those more common inflammatory or connective tissue diseases.
So the main takeaway here is most cases just happen, idiopathic, but maybe around 30%, nearly a third, have some underlying systemic thing going on. Especially if it's recurrent or the nodular type, you need to think about investigating further.
Precisely. Which kind of leads us nicely into who gets this. Are there specific risk factors that make someone more likely to develop episcleritis?
The notes seem to say it can affect pretty much anyone, right? All ages, genders.
That's broadly true, yes.
Yeah.
But there are a few things that might increase the risk. A history of autoimmune disease, either in the person themselves or their family, is definitely a factor. Also, maybe exposure to environmental irritants, dust, chemicals, that sort of thing, could play a role for some. And like with many conditions, there's probably a genetic predisposition for some individuals too.
Right. Okay, so let's zoom in a bit. What's actually happening biologically in the eye during an episode? The pathophysiology.
So at the heart of it, it's inflammation of the blood vessels, specifically the ones in that episcleral tissue layer.
The superficial ones.
Exactly, the superficial ones. The idea is this inflammation gets triggered by that abnormal immune response we talked about.
Okay.
And that makes these vessels dilate, get wider, and become leaky. That leakage and dilation is what causes the redness and maybe a little bit of swelling that you see. Think of it almost like a localized hive or allergic reaction, but in that specific eye tissue.
Okay, so that vessel reaction causes the redness. Now, when someone comes in with a red eye, it could be a bunch of things. How do we differentiate episcleritis from the other common culprits?
Yeah, the differential diagnosis is key here. Top of the list, the most important one not to miss, is scleritis because it's so much more serious.
Right, the deep one.
Exactly. Remember, the pain is usually a big clue, much worse than scleritis. Then you've got to think about a conjunctivitis pink eye. That's usually more widespread redness, often involves discharge, maybe crusting. Uveitis is another one, inflammation inside the eye. That often comes with deeper pain, light sensitivity, maybe blurred vision. And of course, don't forget simple things like contact lens problems, which usually have a clear history.
Okay. The notes also briefly mention differentials for posterior scleritis. That sounds a bit different. Why is that relevant?
It's a good point. Even though our main focus is episcleritis, posterior scleritis affects the back of the sclera, so you might not see that obvious external redness.
Oh, okay.
But it can cause pain or vision changes, and it can mimic other serious things. So if someone has eye pain without obvious anterior redness, you might need to consider posterior scleritis, but also rule out things like optic neuritis, retinal detachment, choroidal tumors, even orbital inflammation. There are also rarer things like uveal effusion syndrome or Vogt-Koyanagi-Harada disease.
Okay, quite a list for the back of the eye.
Yeah. It's just important to remember that not all scleral inflammation presents with obvious redness at the front.
Good reminder. Okay, back to episcleritis itself. How common is it, really? What's the epidemiology look like, say, in the UK?
Well, based on UK data, the number of new cases each year is around 41 per 100,000 people.
Okay.
And the prevalence, the total number of people with the condition at any given time is about 52 or 53 per 100,000.
So not super common, but not vanishingly rare either.
Exactly. It tends to affect younger to middle-aged adults most often, maybe 20s through to the 50s is the peak time. And the key characteristics, again, are that it's often recurrent and usually idiopathic. Compared to all eye inflammation cases, it's considered relatively less common overall.
Right. So let's picture a patient walking in. What are the classic clinical features? What are they likely to tell you? And what would you see?
The most obvious thing is usually that localized patch of redness, often just in one sector of the eye. They might describe it as mild discomfort rather than sharp pain, maybe a gritty feeling or a sort of dull ache.
Grittiness, yeah.
Sometimes their eye waters a bit. And they might be slightly sensitive to bright, light, mild photophobia. Usually it's just one eye, but it's worth remembering that in maybe 40, even up to 50% of cases, it can actually be bilateral, affecting both eyes.
Both eyes, okay. Now let's hammer home that crucial distinction again. Episcleritis versus scleritis on examination. What are the absolute key signs to look for?
Okay, several things. One really useful trick is to gently press on the red area, maybe with a cotton bud after anesthetic drops. In episcleritis, those inflamed vessels are superficial, so you can often move them slightly over the underlying sclera. They're mobile.
Ah, the mobile vessel sign.
Exactly. In scleritis, because the inflammation is deep within the sclera itself, those vessels are fixed, they don't move.
Got it. What about those phenylephrine drops we mentioned earlier? Remind us how they help.
Right, phenylephrine. It's a vasoconstrictor, meaning it narrows blood vessels. Crucially, it mostly affects the superficial vessels of the conjunctiva and episclera.
Okay.
So if you put phenylephrine drops into an eye with episcleritis, the redness should significantly fade or blanch because those superficial episcleral vessels constrict.
Right.
But in scleritis, the main inflammation is in the deeper scleral vessels, which aren't really affected much by topical phenylephrine. So the redness persists. It's a very helpful diagnostic test.
Brilliant. So blanching suggests episcleritis. Persistent redness points more towards scleritis. What about the patient's description of symptoms?
Pain difference.
Huge difference, usually. Episcleritis discomfort is typically mild, maybe an ache or irritation. Scleritis pain is often described as severe, deep, boring pain. It can radiate to the forehead or jaw, often wakes them up at night, and gets worse when they move their eyes. That severity of pain is a massive red flag for scleritis.
Okay, severe pain, think scleritis.
Definitely. Also, episcleritis usually doesn't have other associated eye symptoms. Scleritis, though, can come with things like blurred vision. Visual acuity is typically normal in episcleritis, but it can decrease in scleritis, sometimes gradually.
And if you have a slit lamp, what might you see differently?
The slit lamp lets you see the depth. In episcleritis, you see those dilated, engorged vessels clearly in the episcleral layer. They might be in a sector or all over.
Yeah.
If it's nodular, you'll see that raised, translucent white nodule.
In scleritis, you'll see inflammation involving deeper layers, scleral vessels, as well as episcleral and conjunctival ones. The sclera itself might look a bit swollen, maybe even take on a slightly bluish hue due to thinning in chronic cases. And a key sign for scleritis is globe tenderness. It actually hurts when you gently press on the eyeball.
Ouch.
Yeah. And in really severe necrotizing scleritis, you might see yellowish areas, which are areas of scleral thinning called scleromalacia perforans, though that's thankfully rare.
That comparison is really helpful. Are there other eye problems that might point more towards scleritis?
Yes. Things like inflammation spreading onto the cornea that's rare in episcleritis but can happen in scleritis. Also, complications like glaucoma, uveitis, even retinal detachment or cataracts can be associated with scleritis. Sometimes people with sclerais even notice rapid changes in their glasses prescription.
Wow.
And one last tip. Always examine the sclera properly in good daylight. Pull the eyelids right back. Sometimes subtle signs of scleritis can be missed otherwise.
Good practical advice. Okay, so someone comes in, red eye, you've done your exam. When do you start thinking about doing extra tests, blood tests, scans?
Well, for most cases of episcleritis, the diagnosis is really clinical. It's based on what you see during a careful eye exam, looking at that pattern of redness, checking vision, making sure the rest of the eye looks okay.
So not always necessary to do lots of tests.
Not always, no. Especially for a first episode of simple episcleritis where the history and exam don't suggest anything else is going on. If it looks typical, you often don't need further investigations.
So when would you order blood tests or other things?
You'd start thinking about it if you suspect an underlying systemic disease. So for instance, if someone has recurrent episodes, especially frequent ones,
Okay.
or if they have the nodular type, which we know is more linked to systemic issues, or if they have other symptoms that raise suspicion, joint pain, rashes, gut problems, that sort of thing. In those cases, you might consider blood tests like an ANA, anti-nuclear antibody, rheumatoid factor, maybe checking their uric acid levels. Basically, you're screening for those common associated conditions.
So investigate more if it's recurrent, nodular, or if there are other systemic red flags.
Exactly. Those are the higher risk cases where you're more likely to find something that needs managing alongside the eye inflammation.
Okay, that makes sense. So how do we actually manage the episcleritis itself? What are the main treatment goals?
The main aims are pretty straightforward. Ease the patient's symptoms, the discomfort, the irritation, and reduce that inflammation.
And what are the usual steps? What do you try first?
Often you can start conservatively. Simple lubricating eye drops or ointments can help with any grittiness or dryness. Cool compresses can also feel quite soothing.
Just comfort measures initially.
Yeah, for mild cases, that might be enough, and it often gets better on its own anyway. If the inflammation is more significant or the symptoms are bothering them more, then topical NSAIDs, nonsteroidal anti-inflammatory drugs in eye drop form are often the next step.
Like ibuprofen drops, sort of?
Sort of, yeah. Things like diclofenac or ketorolac drops. If that's not enough, or for more severe cases, then a short course of topical corticosteroids might be needed. But you use those cautiously because of potential side effects.
Right, like eye pressure changes.
Exactly. And then for really severe episcleritis or cases clearly linked to a known systemic condition that's flaring up, you might need systemic treatment like oral NSAIDs or sometimes even oral corticosteroids or other immunosuppressants, usually managed alongside a rheumatologist or relevant specialist. Oral NSAIDs can actually work quite well for nodular episcleritis too.
Okay. And when should you think about referring the patient to an ophthalmologist, to the eye clinic?
Referral is generally needed if an episode is particularly severe, if it's just not getting better with the initial treatments you've tried, or if someone is having very frequent recurrences, say, more than 3 times or so.
Right.
That suggests it might be a more complex case, maybe scleritis has been missed, or there's an underlying condition that needs specialist assessment and management.
Okay. So, assuming it is just episcleritis, what's the long-term outlook? What's the prognosis?
The prognosis is generally really good. That's the main message. Episcleritis is typically self-limiting.
Self-limiting meaning it goes away on its own.
Yeah, it usually resolves within, say, a few weeks, maybe up to a couple of months, often without causing any lasting damage to the eye. The outlook is excellent for most people.
That's reassuring.
It is. The main thing to be aware of is that recurrence is definitely possible. It can come back, especially for people who have those underlying systemic inflammatory diseases.
Right. If the underlying condition flares, the eye might too.
Precisely.
And what about complications? Are there any serious risks associated with episcleritis itself?
Thankfully, significant complications directly from episcleritis are rare. It's generally benign, remember. The main risks often come from any underlying systemic condition if one is present.
Okay.
There is a very small theoretical risk that episcleritis could potentially progress to involve the deeper layers and become scleritis, but that's not common.
Ew.
Very occasionally, you might see some mild corneal involvement or maybe slight thinning of the sclera after multiple severe episodes. And as we mentioned, if topical steroids are used long-term without monitoring, you could get steroid-induced glaucoma or cataracts, but these are generally uncommon if it's managed properly.
So prompt diagnosis, appropriate management, that usually prevents problems.
Yes, absolutely. Getting the diagnosis right, differentiating it from scleritis, and using treatments appropriately usually leads to a great outcome with minimal risk.
Okay, great. So let's try and wrap this up. Key takeaways for episcleritis. It's that generally benign, self-limiting inflammation of the superficial episclera. Redness, mild discomfort are typical.
Right. Often idiopathic, but always keep those potential systemic links like RA, IBD in the back of your mind, especially if it's recurrent and nodular.
And the absolute crucial thing is telling it apart from scleritis. Think pain level, vessel mobility, and that phenylephrine blanching test.
Exactly. Management is usually straightforward lubricants, maybe topical NSAIDs or cautiously steroids. Prognosis is excellent.
Perfect. So a final thought, perhaps, for our listeners revising this.
Maybe just to reinforce that connection when you see episcleritis, especially if it keeps coming back, don't just treat the eye in isolation. Think about the whole patient and whether there could be an underlying systemic inflammatory process that needs attention too. It's about connecting the dots.
Excellent point. Well, hopefully this deep dive has helped clarify episcleritis for your revision. And for more MSRA resources, definitely check out pastthemsra.com and also freemsra.com.
Yeah, lots of good stuff there.
Thanks for tuning in.